Hey, happy Friday afternoon, Facebook crew. Just saw my last patient of the day and of the week and wanted to talk to you about her. So this happens quite frequently here, and thankfully we don't rely on physician referrals. So the physicians that do refer to us usually know, we don't need instructions. You don't need to spell things out for us. We can figure out things, what to do on our own. But just had a patient that was sent in, and she was actually referred by another patient, not from the doctor, but she saw three doctors. She saw three doctors, and I think she's seen two PTs, and she might have mentioned a massage therapist or chiropractor somewhere in there, but she's been having problems with shoulder, upper extremity, some neck, pec, fatigue issues. So I want to give you a quick rundown of what she went through before she got here, and hope this drives home the fact that you should not be listening to physicians. You, if you are a doctor of physical therapy, have 7 years of training and a license to practice physical therapy. You didn't go to school for 7 years and get a license to listen to physicians who are lazy and usually don't know what they're talking about. So I'm going to tell you what happened to her, and along the way point out how screwed up this system is. If you haven't figured out that this system is screwed up, then please start paying attention to what's going on during the day. My bet is you have a really good grasp on how jacked up the medical system is, how broken the physical therapy model is, how we are supposed to be flunkies for physicians who aren't very good at what they're supposed to be experts at. Maybe if they were good at what they were supposed to be at, we could be left alone and be experts at what we're supposed to be good at. So let's walk through this. So patient has left non-dominant shoulder, fatigue, tightness, pain, goes to see physician who is unable to think for themselves, problem solves, use critical thinking skills, get to a root cause of a problem. What's the first thing they're gonna do as an orthopedist when you go see them with a shoulder problem? Let's get x-rays. I can't listen to you tell me what your symptoms are and what the history is and what the mechanism of injury is. I don't know, let's get an x-ray. So she gets an x-ray. X-rays are negative. Well, if the x-ray is negative, you probably don't have all that much going on, so go to physical therapy and do whatever they wanna do with you there. So she goes to physical therapy, and the physical therapy she goes to is in the same office that the physician is in. So if the physician is clueless, how good do you think the physical therapist is? So she goes to physical therapy, pain gets worse. What does she do at physical therapy? Needling, massage, corrective exercises, pain gets worse. Goes back to the physician. Oh, well, I don't know. I guess we'll have to take an MRI now because I can't problem solve. No critical thinking skills. Let's get an MRI. MRI comes back negative. This might be thoracic outlet syndrome. Does thoracic outlet syndrome test? Negative. Let's get a cervical MRI. Negative. So we've got a shoulder set of films, negative. We've got a shoulder MRI, negative. We've got a cervical MRI, negative. She's negative for all special tests, all kind of tests for thoracic outlet syndrome, but we're sure that she has thoracic outlet syndrome anyway. What do we do now? Well, we send her back to the physical therapist that screwed up the first time. Okay, so now we're back with the physical therapist doing more bullshit and more physical therapy fuckery, and guess what? She gets worse. Oh, go figure. So now she goes to a specialist, and the specialist scratches his head and says, well, if all the imaging is negative, but you still have fatigue, but she doesn't have radicular symptoms, she has no numbness, tingling in her hand and her elbow and her arm, well, then it must be thoracic outlet syndrome, says the specialist who sees people for thoracic outlet syndrome. So when you only see people for a certain thing, everybody that you see ends up having that certain thing. So she sees this guy, Vascular Institute specialist, and diagnoses her with thoracic outlet syndrome, and says, you need to go to physical therapy. And she says, well, I've been to physical therapy. So luckily her friend says, go to this physical therapist, and she comes here. Thankfully, the vascular specialist gave me an entire research rundown of all the things that I should be doing with her as a physical therapist, because I'm too stupid to know what I'm doing. I only have 7 years of education. But because so many physical therapists have fallen into the world of complete fuckery and do bullshit for their job, then the rest of us all look like dumbasses too. So that's why he sends me this. So let's look at this treatment strategies and assessment and diagnosis of thoracic outlet syndrome. Holy cow, I've never heard this before. Now, here's why people have thoracic outlet syndrome. Don't you know this? They have weak cervical flexors, tight pecs, and then tight suboccipitals and upper trapezius, and then weak mid-lower trap. So that's why people have thoracic outlet syndrome, even when they don't have any symptoms of thoracic outlet syndrome. Okay, so what should we do? Oh my goodness, thank you for telling me what causes thoracic outlet syndrome. Now, could you tell me how to treat all of those things that are going on with people with thoracic outlet syndrome? Well, we're gonna do nerve glides and tilting and stretching of all the tight muscles, and then we're gonna do strengthening of all the weak muscles. Whew, thank you for telling me this. I couldn't have figured this out. How do I know that they're weak? Well, because the paper told me so. I don't have to assess that. How do we know that they're tight? The paper told me so. Her symptoms of thoracic outlet syndrome, even though she doesn't have any of them, tells me that that's what she has. And of course, anytime something is tight, we think like a third grader and say, well, then we need to stretch it and massage it. And anytime something is weak, well, we give them exercises, even though we're physical therapists that probably had no education as to how to do exercise in PT school. And even if we did, corrective exercises don't work, but that doesn't matter because the paper tells me what I should be doing. Thank you, paper. Thank you, specialist. Now we look at patients and we have them squeeze their muscles and see what position their scapula is in. Like everybody's scapulas should be in the exact same position. And if somebody has a scapula that's not in the exact same position that the picture says they should have, then they have weakness and tightness that we need to stretch and do correctives for. Oh, man, I've learned more in the last 15 minutes than I learned in 7 years of school. What else could we do? Oh, we could do taping. Ah, that will fix it. Why didn't the physical therapist she saw before just put some tape on it? Holy cow, how did I not know that? And then we've got more correctives for the weak muscles that are weak because the paper says they're weak. All right. Now we have more stretches. Let's stretch those tight muscles because physiology says that would be a great idea. Let's stretch an inhibited muscle, which will cause it to become more inhibited. Awesome, fantastic, thank you. All right, then where should we give them a massage? Where the tightness is. Holy cow, I couldn't have figured that out. Oh my goodness, most elementary school kids could figure this out. Okay, now when those don't work, let's tie a belt to their shoulder and have them hang on a pull-up bar with the belt so they can do a mobilization of their scapula. Fantastic, I bet that would work too. Oh, and when that doesn't work, let's do a mobilization of the first rib because all of my pecs and my clavicle and my shoulder and all of this that's over top of my first rib wouldn't get in the way of jacking on my first rib with a belt around my body and then have somebody yank on it. That would fix the thoracic outlet syndrome. So the take-home story is that you as a physical therapist are a moron, and what you should be doing is waiting for physicians to give you packages of research and evidence-based practice because that's what works. Because everybody across the spectrum is the same. Stretch the tight shit, exercise the weak shit, everybody gets better, and guess how often that happens? Never. So what did I do with this patient? I assessed her. I used critical thinking skills and my knowledge of neuromuscular physiology and problem solving and root cause analysis to figure out that she's got inhibited pec major because she's been stretching the shit out of it. And she's got an upper trap that's not doing anything. Her pec minor's fine. Oh, by the way, I did do special tests, which I never do, but I did all the thoracic outlet syndrome special tests, and she was negative for all of those. So I'm thinking, I kept on asking her, why did they say you have thoracic outlet syndrome? And she kept on saying, I don't know. Every test they did said I didn't, but then they came back and said I did. Thank you, physicians, you geniuses. So after we got done, got her back to full range of motion, no pain, no tightness, no nothing. So now I said, let's see if we can make you fall apart. So we went and did some really easy exercises because she likes to do CrossFit. So I want to see how fast she would fatigue if we sent her back to CrossFit. She fatigued within about a minute of doing some pretty rudimentary TheraBand exercises. So what do you think is going to happen if she goes back to CrossFit? She's going to be an absolute disaster again. So I gave her isometrics, which are muscle specific to help reestablish normal neuromuscular facilitation, which should help her maintain normal muscle firing so we can gradually work on muscle endurance, not muscle strength. We're not trying to do correctives. We're doing muscle specific exercises to increase facilitation, which should help us increase, I'm losing my train of thought here after I go nuts. Increase her endurance. Then once we do that, then we can go back and reassess, and then we can start working on strengthening things. So these are the things that you should be working on and thinking about as a physical therapist. When a physician gives you a referral or a diagnosis that you know is bullshit, let your patient know that you're not going to be following their cockamamie protocols and suggestions. You are a doctor that can problem solve on your own. So you're going to do your own stuff, and hopefully that's 180, because now she's actually got a plan to move forward. So she's supposed to go back to see this specialist in April for injections into her pec and her upper trap and her scalenes, which she didn't even have a problem with her scalenes, to solve this problem. So I'm hoping that we've got everything situated, and then I can send the specialist and the orthopedic genius a little note that said, if you would have actually taken 30 seconds or a minute to do a functional screen on this patient and then got a little bit more analytical with your testing, you could have figured this out before she got screwed over for months. But do you think they would listen to that? No, because physical therapists for so long have just bowed down and listened to physicians' bullshit and settled for physical therapy fuckery that we all look like morons now. So please, don't be a moron. Think for yourself, problem solve, use science as your guide, not bullshit evidence-based practice. If you want to get in the shift and learn how to do all this, make sure you get with me and I will get you in.